So welcome to Karla Olorenshaw.
Well done. Beautiful.
Yes.
Yeah, you did.
Okay, got it right. So Karla is the Advanced Care Planning Facilitator for Te Whatu Ora. And she's kindly come and given her time today to discuss this really important topic, which is something we get asked so many questions around. So it's good that we have a space to ask questions to the right person. So I will let you take over, but just really quickly with the, if you are needing the toilet, there's toilets right outside this door, and also for our safety, nearest fire exit, which is there, and then we would make our way round to the front to where the bikes are stored. That's
Thanks.
it from me.
Good to know.
I am Lauren, I'm the Health and Wellbeing Lead here for those who haven't met me before.
Okay. Thank you very much.
Thank you.
Lovely, we've just got another arrival. Good morning. Welcome. So, good morning everyone. Thank you for having me along to have a wee bit of a chat this morning around advanced care planning. As Lauren said, my name is Karla Olorenshaw. I'm a registered nurse and I'm from Canterbury originally. So if any of you are wondering, I wonder if she's related to, the answer is yes. Whoever you think I might be related to, I am. Because I grew up here in Canterbury, turns out my dad was from a really big family, and so everybody seems to have had a neighbour or an old school friend or somebody over the years who was had the same last name as me, and I'm like, definitely they're related to me. So yeah, I grew up in Canterbury. I did my nursing training at Christchurch Polytech, back when it was called Christchurch Polytech, before it was called ARA, and but I never really worked here after I qualified. I did my training and then I worked in Nelson for a year and Auckland for a year because I wanted to see a wee bit of my own country before I went and did my OE. My OE lasted a somewhat protracted 20 years in the UK, somewhat longer than my parents intended that I should be away, but anyway, I eventually came home. So I lived over there. I was a cancer nurse for 20 years. And I used to work in this big, busy central London hospital. I worked there for 17 years as a cancer nurse. And I was particularly interested, one of my roles was in clinical, the title was Clinical Practice Facilitator. And I was working with a lot of people who already were fairly expert at what they were doing. And I was like, well, how do I facilitate practice when actually people are already pretty good? And so I was part of a clinical debriefing team, and we would go around this big, busy hospital, and we would debrief clinical events that people wanted to talk about and talk through as a team for the purpose of learning. And what we ended up debriefing a lot was CPR events, the events where people were doing chest compressions and rescue breaths on people. And this was back in the day where we were doing CPR on anybody and everybody. People who were known end of life, frail, elderly, advanced oncology patients, and our collective learning as a team that were running these debriefs. And we were debriefing, we were available to debrief anything and everything, but that was the thing that repeatedly came up. And our collective learning was, what on earth are we doing, not having early conversations with people about how they want to be cared for. And I looked after, I did a debrief one time for a group of oncology nurses, and they actually thought the event had gone fairly well. They had started doing CPR on this man, and his wife had said, stop, 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 he doesn't want this. And so they stopped. They didn't carry on anymore. He had a diagnosis that it was not a surprise, but that his heart had stopped. And it was only, and so they thought the event had gone well. And it was only in hindsight that I kind of thought, that's great that his wife knew and she could talk confidently about what he didn't want, and he was able to get care aligned with what he didn't want. But I was like, well, how come we as a healthcare team looking after him didn't know that he didn't want that? And all as I could think was that we didn't ask. We didn't ask him what he wanted, we didn't ask him how he wanted to be cared for, and we hadn't checked with him before, during his admission process, how he wanted to be cared for. So I was teaching a little workshop in London called Talking DNA CPR before I came home, and so that's talking, do not attempt resuscitation, do not attempt, and because having these conversations are really tricky, and it's tricky for everybody. It's tricky for the healthcare professionals to approach the conversation without implying everybody's dying when they're not, and it's tricky to be the person on the receiving end of that conversation and hear this person asking questions about how do you want us to care for you, without thinking, oh, what do you mean? Should I be worried now? When actually they're not expecting anything necessarily bad at this time. So these conversations are tricky for everybody. Turns out internationally there's been research on how to have these conversations well, and our kind of learning over the years has been around starting early and starting while people are well, so that we can have these conversations in a time that we are feeling well enough to engage in the conversation and able to confidently just start thinking about our planning early and dip a toe in the water and then kind of get back to our normal life. I'm getting quite warm in here, so I'm going to get rid of this thing. So anyway, I'm still only on the first slide. That's what I'm going to be covering today. That's how I got into advanced care planning. So today I'm going to cover what advanced care planning is, why we would want to do a plan for ourselves, how it helps, and this thing, it's relatively new, shared goals of care. It's been around since 2023 in New Zealand. Lots of hospitals adopted shared goals of care in 2023. So that's what we're covering today. I've done all of that, I don't need to rehash that again. I do lots of education for healthcare staff, healthcare across the health sector, and for health consumers, lots of consumer groups in all different locations, but around Canterbury is where my role is based. People often ask me where I'm based, and I'm like, I don't know, depends where I am each day, it varies quite a lot. So, advanced care planning, there is some confusion sometimes between what I've handed out to you as a booklet, and that is an advanced care plan. And there's a difference between a plan and planning, and advanced care planning is a much bigger process than just the booklet. But the booklet really helps with giving us a place to write some bits and pieces down. So advanced care planning, it's a process that helps people think about and talk about their values, goals and preferences, what matters to you. It's a plan for you, about you, and it's about your values and preferences. We're not doing advanced care planning necessarily. We can't do it for somebody else, I can only write mine for me, but if I'm helping you write yours, then I write down it's only your voice speaking within the advanced care plan. But it's a wider process. And it's mostly based around what matters to you, what's important to you, and it's a way of communicating what matters to you in a way that others can access it and see it. If you're not able to communicate for yourself at that stage, people can find it and read it. We're thinking about our current health as we are now and what might be ahead for us in the future. So this is a busy picture looking at the different parts of advanced care planning, all different parts of the process. So like I said, this is the advanced care plan. It's a booklet. Lots of us do an advanced care plan maybe when we're more well and we have some time to think through what it is we want to write down in our own plan. And there's no expiry date on this plan. This plan stays in place until we update it and change it. And like, I have an advanced care plan now, and I'm, how old am I? I'm 48, and no diagnosis, and I know my advanced care plan will change over the years, and I expect to update it and change it as my health progresses and as things change over the years. So people often say to me, oh, but what happens if I change my mind? I'm like, fine. I would expect you to change your mind on some things as things move on, because we will all shift our thinking. But also, equally, family might move to Australia and you want to update their mobile number. It can be really practical things that we're just changing in our plan, and that's absolutely to be expected, and it's fine too. There's this thing that I was talking about before, shared goals of care. That's a plan that's focused on an admission. They call it an episode of care, and it's like, what does an episode of care mean? It's the time that we're admitted to hospital, or a time that we're admitted into an aged residential care facility maybe. And so we would only have a shared goals of care if there was a specific event that we might have a doctor looking after us and a healthcare team, and we probably are admitted somewhere receiving some care. That will end on discharge. But these two plans can work together. So if we're not able to speak for ourselves, the advanced care plan can inform shared goals of care, and the shared goals of care we might have some conversations while we're in hospital and be told some things by our doctors, and we go out, get discharged home, and we're like, maybe I'll update my plan again. So the information can kind of transfer across. And this guide is the guide that I use to teach healthcare professionals around having these conversations, to help make it a wee bit easier for them, because it's got some nice language that we can all use. And it's questions like, what are your priorities if your health does get worse? And so we use that a lot for teaching.
So does this plan go online somewhere, or is it just
in the South Island? We have Health Connect South, or Health One. It's our electronic medical record, and it's across the whole of the South Island. So part of the process and part of my role is the general practices in Canterbury get paid a subsidy for doing the advanced care plan. So those appointments are usually free or cheaper, a lot cheaper. I can't guarantee what every practice is going to do, because they're all independent businesses. It's worth checking at your practice how much they might charge you. But for people who meet subsidy criteria, those appointments are usually free or cheap. And one of the things that we're paying for is for it's often the practice nurse, sometimes it's the doctor, usually it's the practice nurse. They go through and talk through the plan with you, they sign it off, and they type it into Health Connect South Health One, so that then it's shared and accessible to hospital, healthcare staff, your general practice team, people in an aged residential care facility, and St John's as well. Paramedics have access to it. Yeah. So it's not on the internet. It's in a very secure electronic health system. And I was going to say something else, and now it's slipped my mind. So yeah, that's part of that's right, I was going to talk about people who don't meet subsidy criteria. I know I don't meet subsidy criteria, so I phoned my practice nurse and asked her how much she was going to charge me for an appointment, and it was $32 for a nursing appointment. And she did kind of sigh at me though and go, oh Karla, you're the most well person who's ever wanted to do a plan. And I was like, I know, it's a little test. You have to get back to me. So she did, and I was like, fine, $32. If that, some of the practices for a while were charging astronomical amounts, but that's entirely unnecessary, so we've tried to sway them away from
And
that.
that's for an advanced care plan.
An advanced care planning appointment. So the advanced care planning appointment The plan is
What
free.
you write out.
The plan is free and available
Yeah.
on a
It's
website.
just the appointment.
At the appointment and the conversation and the support that's required, and there's a subsidy for that, and so
Can I ask?
Go on.
So that, around that $30-something, that is specifically for advanced care?
no, for my
For
appointment,
you,
yeah,
Yeah.
was a nursing appointment, and they just charged me their standard
because
rate.
that sounds very reasonable, and I was just
That's what I thought.
talking to Lauren, because I mean, I had cause to go to, see my practice nurse for something recently,
Yeah.
actually to have a couple of, to have 3 steer strips applied to my skin, and I provide the steer strips, and I was charged like, I think what did I say, 60 something, it was
Wow.
as much to see the GP.
I mean, it was a couple of years ago, so they may have put their prices
I mean,
up.
I was
to-
gobsmacked.
Yeah.
I worked as a GP, as a practice nurse,
Yeah,
and I mean, my services were free.
yeah.
So, I mean, I was gobsmacked. I mean, I
That's
often
amazing.
say to people, oh, see your practice nurse if you can't see your GP. I thought, I'm going to stop saying that.
Yeah.
Because,
That's why I say ask how much it's going to
Yeah.
cost.
Yeah.
Yeah.
If it's completed other than at the GP, like for example at a residential care facility, can it still go into the same electronic system?
It can. They tend not to do it.
Okay, right.
Because of the complexities, I think, with the age residential care facilities, they tend probably to not have the time, I think is what it is, to put them on. And so, yeah, they tend not to do it. Most people go through the general practice teams. Some of the social workers and hospital team members at the hospital do it, but that's depends. Yeah, it's pretty small. Most people, huge, vast majority is through the practice. Sorry, you have a question?
I started doing it myself online.
Yeah, that's great.
It is a bit glitchy to save the next iteration though.
Yeah.
Yeah.
I was going to say, because I've given you a paper booklet,
Yeah.
but there is an electronic one that you can download. There's a website called myacp.org.nz, and I quite like that. It's our website, it's our national website, but I like that it's called myACP because it's your ACP. And there's a tab at the top that says your plan, and there's lots of resources that you can download or order, but you can download and have them, you save them to your laptop. That's how I did mine. I saved mine to my laptop, filled in the PDF, and then emailed, I think it was, to my practice nurse so she could print it out. And some of them allow an electronic signature, depends on which version you're looking at. I think I'll carry on. Any other questions? No? You can have more while we're talking, that's fine. So, the plan is around allowing you to kind of have a say in your own care. It allows for early thinking and having time to discuss with your support crew, your family, your whānau, your whoever are your people. And we've found that it helps reduce worries for individuals and people and for families as well by having some of these early conversations. For all of the years that I was a cancer nurse, sometimes I avoided having these conversations because I thought, the people I was looking after already had quite enough going on. I really didn't want to make their worries. Welcome, come on in.
No, I'm sorry.
No, you're fine.
Oh, no.
Grab a seat. We've found that it helps reduce worries because I didn't want to make people's worry worse, and so I avoided some of the conversations. And actually we've found from the research that the opposite is true. By having some of these conversations early, we can have a wee think about things, we can have a wee talk about things, and apparently early planning is a known intervention for reducing worry and anxiety. And so even for people who are actually physically likely to live a very long time, if they're super anxious about something, I'm like, put a plan in place around that thing that you're worried about so that you can put that worry down because you've already written it down, and then you get on with your life. And that's quite nice too, because you don't need to hold all of that worry in your head. It's like you can write a plan down and then move on, because you know that people can access and support, do whatever it is that you want to do at a time that you might not be able to communicate for yourself. So identifying and communicating your preferences is again another reason why we might do one of these plans and what it allows for. So the values, goals and preferences, and you're communicating that to your future healthcare team and to your family, whānau, your support crew, so that they can, even in a time when things might be a little bit stressful, actually family can look at the plan and go, oh yeah, that's right, she did tell me that, I forgot, or oh yeah, it was written down, and there it is in black and white. And some people will have been involved in these conversations. Other family won't have been involved in these conversations, and this will be new for them. But it helps people understand what the plan was. This was a diagram that I quite like. The national team had it developed, and it's trying to depict the kind of fluid nature of advanced care planning. That actually, for all of us, will go through times in our lives where we're thinking about this quite a lot, and at other times where we're really not thinking about this at all, and it's kind of very much in the back of our minds. One of our senior doctors who works locally, and she's a geriatrician who works very much in the older adult space. She was saying actually, when we all get down to this stage where we're not able to talk for ourselves, or the person is actually in their last days of life, she said care planning is actually really hard if we're just getting started at this stage. And I kind of thought, oh, if she's going to say that, if Jackie thinks it's really hard to get started at this stage, then this isn't a lack of education or skill or more practice, or there isn't a more of anything that's actually going to make that better. It's just really hard if we get started down here. And I said to her, oh, we just need to start earlier then, when people are more well, because she looks after people who've lost capacity a lot. And she laughed, because obviously from an individual point of view, you can't rewind the clock on it with an individual and rewind 5 years and go, oh, actually, how would you like to be cared for? And I was like, but from a system point of view, we can all start these conversations much earlier on down here while we're well, or more well, and so we have time to think these things through. And partly it's about helping families come to terms that eventually, a long way in the future, it helps them come to understand what good care looks like, and so that they're not advocating on your behalf when actually they're then advocating for things that you don't really want, or you wouldn't necessarily have valued or asked for, because then everybody can be on the same page. And also family have had time to ask questions, worry about things, come back with another question, talk to the healthcare professionals, and everybody kind of can move forward together, is the general idea. And there's lots of opportunities. Sometimes we can do these things while we're well and we're at home. Sometimes these conversations are taking place at our general practice team, and other times it can be prompted by a visit to the hospital or a stay in hospital, and then we kind of think, oh yeah, actually it's time to put some things in place now, and it can be a prompt. And this one is, again, some people get started when, or have changed their plan again when they're living in a kind of supported care environment. This is our Easter egg slide. Obviously, looks exactly like an Easter egg. And the best thing about a Cadbury's cream egg is the crunchy chocolate around the outside.
And I see it's the fattest part.
It is the fattest part. And however, if we had a solid chocolate Cadbury's cream egg, that would be kind of hard to eat. And if we would also not be a Cadbury's cream egg. But it would be really hard to eat, it would be really hard to do anything with. And so having the gooey centre-y bit in the middle is what is also really yummy. And it makes it easier to use and work with. And so if we just had lots of conversations around advanced care planning actually that would be really hard to use and really hard to work with. And so we write some things down in a advanced care plan as a kind of summary of all of the conversations and thinking that we've done. And in the advanced care plan, there can be some specific advanced directives. And like the weird yellow blob in a Cadbury's cream egg, if you took that weird yellow blob out of the cream egg, that would definitely be a thing that you would have some questions about. You'd be like, what is this weird yellow blob? Why do I have it? What am I meant to do with this thing? But it's only when it's in the middle of the Cadbury's cream egg that you kind of know what it is. It's meant to be the yolk. It makes sense because that's where it is. And advanced directives are kind of similar. Sometimes advanced directives can also be called a living will. And having these things by themselves obviously mean a lot to the person, but they don't necessarily mean anything to other people who read them. And so having an opportunity to talk the advanced directives through and summarise, because we might have questions like, why are those advanced directives like that? What are you hoping to achieve? When do you mean for me to apply them? In what circumstances? So there's lots of questions to have around these advanced directives, and we can make sense of them within the advanced care plan. And because these things exist together, we can then have more conversations. So the information can flow in to these documents and it can flow back out again and be a prompt for communication, generally while we're well and able to talk for ourselves, and again, if we're not able to communicate for ourselves. The people who are living with serious illness have really said that they appreciate that the focus is about living well. People can get a little bit put off by the advanced care plan because they think it's death planning, and actually it's more focused on helping you live your best life while you're still living your life, and having that be the focus. And it's like, what are your priorities and goals? How can we help you achieve your priorities and goals? What matters most to you? And what treatments are going to help you achieve your goals is the focus of the conversation. People have said that they feel more in control, and they felt that living with serious illness was really hard, and they felt like they were losing control a lot of the time, and so they appreciated these care planning conversations as they were able to regain some control and some decision making, and they felt empowered through having these conversations, and it made it a little less scary. And these, as I've said, it's super helpful to include family and whānau in these conversations, and often people will say they weren't so worried about the kind of feelings of control and being empowered, but actually they were wanting to relieve decision-making burden from the people they cared about and their family and whānau. They said, I can make decisions for me so that they don't need to be put in a position to have to make tough decisions on my behalf. And some people really appreciated that element. Some of the healthcare team have said they really appreciate the kind of collaborative approach, the we'll figure it out together. The person was able to be the expert in themselves about what mattered most to them, and the doctors and nurses were able to be the expert in their medical or healthcare speciality, and actually they could work together around, these are the goals, this is what we're trying to achieve, what treatments have you got to try and help me achieve my goals. And so, yeah, the healthcare team particularly liked that. And everybody liked that it was decreased anxiety and depression for people, which was a big relief. Helps put down some of that worry. So shared goals of care conversations, as I've already touched on, it's thinking about what matters most to the person. One of the things I find a little bit tricky about shared goals of care is that if it's your first conversation and you're going to hospital, none of us go to hospital when we feel well. We're already having a not very good day if we're ending up in hospital. And then we get asked something, it might be something like, what do you want me to do if your heart stops? And it's like, ugh, I don't feel very well. I've got a terrible chest infection and now you're asking me that rather tough question. It's like, make me better, thank you. I would like that. And so I encourage people to start thinking about it early, just to take some of that shock out of it if you get asked that in hospital, because all of us might get asked that in hospital, and they are encouraging these conversations to be had with everybody, even the people who were not expecting any problems or deterioration while there's during the admission.
So you're saying even if you've got an advanced care plan, you are likely to be asked, say you go into hospital with pneumonia.
Yes.
You will be asked whether you do not resuscitate or not. You're going to be asked that.
I'd like to guarantee that. I can't guarantee that. That's what we're working on.
Yeah, so it's not informed. It's going to be asked, even though it might be.
It's a really good point. While you're able to talk for yourself, they will talk directly to you, and some of them will read the advanced care plan and then talk to you and say, I mean, ideally, they would read the advanced care plan and say, I read in your advanced care plan. We also know that some people haven't quite got to the stage of logging it, having it lodged on the electronic medical record. They haven't quite made the appointment yet, but they've started that thinking and planning. And so it may be if you're halfway through writing it, and then there's a hospital admission. Just the process of starting the thinking and planning in your own self means that if you go to hospital with a pneumonia, you're like, this is what I want. I know, because I've already thought about it. And because you've already thought about it, you can then communicate that really clearly. And what we're seeing is that the shared goals of care plans are much better just because of the thinking process that's gone on, and then the clear communication that you're able to bring.
So is this an actual document?
Yeah.
This thing? Okay. Yeah, because recent experience with hubby with Parkinson's, so he does have an advanced care, it is lodged electronically. They did, the registrar did exactly what you have just said. Yeah, so they told hubby that yes, we know you've got an advanced care plan, we have read it.
Great.
Yeah. So that's
The system worked.
yeah.
So is there any highlighting on notes about things like no antibiotics or do not resuscitate?
Yeah, so there's different systems. On one of the systems, it's called Health Connect South. There's alerts if the care plan, advanced care plan is lodged on Health Connect South. There's an alert that says care plan, and it does. There is a kind of in the hospital they work in a system called Cortex. So they have to get out of Cortex and go look in Health Connect South. And at the moment, we're like, you have to go look in.
Do they have to for other reasons as well?
Yes, they do. They do have to for other reasons. And so we're doing lots of work to make sure that they are connecting all of those. It's, nothing's 100%, but they are healthcare professionals in the hospital. They're realising that, actually it helps. It really helps them and it really helps our patients.
And Liz told me to get DNR tattooed on my chest, should I?
No. No. The problem with the tattoo is that we can change our minds, and it's much harder to change than an injectable. Yeah, that's right. Yeah. That's right. There is no, because I have heard of people who were definitely very keen that they were not to have CPR until they were in their final couple of weeks of life, and they were like, I changed my mind, I definitely want you to do it. And it's like, and one of the things I have on the list to talk about is that actually CPR in itself it's a bridging tool to other things. And if for years I was a cancer nurse, CPR isn't going to cure cancer, and if we haven't managed to cure the cancer, beforehand and then somebody's heart stops, then actually there isn't necessarily a treatment on the other side of the bridge that's going to change it. And so one of the conversations we have now is thinking about recognising when somebody is naturally coming to the end of their life versus when somebody is having an acute event that we can reverse. And CPR is really effective when somebody is having an acute event that can be reversed, and then we can do all sorts of interventions to fix things up. I think one of the things that's like if you watch the movies, people have CPR and then they leap up and they're running around about 10 minutes later. I've never yet seen that in real life. And it's not like the movies. I think for most of us generally, if we're going to have CPR, we're going to be in intensive care for a bit while they fix the problem that actually caused our heart to stop. Then we're going to probably be in Christchurch Hospital for a bit longer after that, and probably most of us would then have a stay in Burwood. And some people, so if you don't want to have all of that process, then actually the CPR intervention isn't going to necessarily be something that's going to help you achieve your goals. And all of us come out worse off than we went into it. Nobody comes out feeling better after the CPR than they did before. And for some people who are naturally coming to the end of their lives, actually it's a loss of independence and increased frailty, and people have expressed regret that actually they said, oh, if I'd known I was going to be like this afterwards, I never would have had it. And so it's like, okay, let's have a conversation about when any of us are getting to that stage in our lives that actually this is not going to give us an outcome that we want. And it's a question that you can ask your medical team or nursing team of like, if I was to have CPR, would it help me achieve my goals? Or at this stage, would it not help me achieve my goals? And obviously it depends what your goals are.
If in our situation, the medical team recommended DNR,
Yes.
so and that was reinforced with the move to residential care,
Yes.
but there was quite a big gap of understanding around why the medical team had said we wouldn't resuscitate. How do you suggest we approach that?
Yeah, so one of the things on the shared goals of care form, one of the statements that's certainly new within my career is that it says CPR can cause more harm than benefit.
Mm-hmm.
And it's useful to maybe ask, what would that look like? Or what do they mean by that? Because everyone's different and it has a different, but it can be, one description I've heard is that CPR can be like being in a car accident, and so for a lot, it can be very intense and lots of bruising, and we can have brain damage after it. And so the kind of because it can be like
So explore the discussion, say, well, you've recommended this, so yeah, what would that look like? That's what you're saying.
yeah.
So we understand how you've reached or why you've reached that
Yes,
recommendation.
that's right, and it can be
Because
around.
presumably you can override it yourself if you chose to against the advice of the medical team.
And that's the nice thing about an advanced care plan working with shared goals of care. If you think, things change, your health might have improved, things might have got better,
Mm-hmm.
and actually you're like, oh no, I want my advanced care plan, I do want to be for CPR. I think they misunderstood, where I am or what my goals were or how much I'm willing to go through. And so that your advanced care plan can say whatever you want, and the doctors can do shared goals of care. Like I said before, it ends on discharge, because just because they've said it once doesn't mean that that's going to be an ongoing decision. And because you might have recovered and got better, actually next time the decision might be different. That's okay. And that's why it's useful to keep that conversation. That's why advanced care planning is a process, because we don't know what's going to happen with our health, and if we get better or go through a phase where we're more well, then actually we want things to be updated and changed. No worries. And actually, this does bring me back to the fact that this is just it's a conversation or a plan for the stay in hospital, for that particular admission, and that allows for flexibility, so that you might have 3 different hospital admissions, and they might be for 3 different reasons. One time you might have a chest infection, one time you might have a car accident, and one time you might be in having surgery. So you might have 3 different shared goals of care plans, very appropriately, depending on what took you into hospital at that time. And they will be taking, and these conversations will be taking on board, you know, your comorbidities, where things are at, what's happening with our health at the time, and what we were doing or what we were like just prior to coming into hospital. And if we were, you know, out and about, independent, going to the shops, that's one thing. If we were very frail, living in a care facility, getting hoist transfers and being very dependent on others to provide us with care, then actually interventions would be very different. So shared goals of care conversations can help you and your whānau feel prepared. It allows you to guide clinical decisions in a way that reflects your values. They are flexible and they're not forever decisions. We have a really nice website, I've already talked about it a little bit before, called myacp.org.nz, and as I said, there's the subsidies available often at with the nurse. So this is the look of the website up there. Any questions? We've touched on the CPR bit already. Any other questions for me at the moment?
What happens if someone is cognitively impaired in decision making? The access of, you know, what happens? So they've got an advanced care plan, they come in and their shared goals of care, and they're being asked questions, and cognitively not quite good.
Yeah. In that case, I would expect this advanced care plan to be much more of a focus in the conversation, because we do an advanced care plan for the time. I always say when we're not able to communicate for ourselves, because when we're not able to communicate for ourselves might really vary. It might be a chest infection and we just can't breathe properly enough to talk and engage. Or it might be that our mental functioning, like even with COVID, people who were, you know, working full time and healthcare professionals, they were, and then just because of the way COVID was, their brain wasn't working properly. And I think there's lots of things, and people were making a recovery afterwards. It's not a kind of life-ending thing. It's just temporarily not being able to communicate for themselves. But then the advanced care plan would be able to be the tool to use some communication. Family, whānau, kind of your named support crew would also be included in that conversation, and people would be checking in with the patient as much as possible, as much as they were able to include in the conversation. But if I'm having that conversation and I have somebody's advanced care plan, it's like, in your advanced care plan you told me X, Y and Z, is that still correct? And people are then able to kind of go yes, no, or if they're not able to contribute, then actually that's fine too. So it's a process from developing a plan and then using a plan is a process as well. Yeah. That's where it helps to have the family whānau support crew read the plan and be part of the conversation earlier, and because then they can kind of say, oh, she always told me, she said she wanted X, Y and Z. And so now I can be the voice and the plan, or if you've changed your mind and anything in the plan, be like, oh no, she still wants that, or updated. Go on.
Just, I went to a U3A discussion about assisted dying,
Oh yeah.
and I just wondered where that was at the moment, because they said if you were in a care home, well, care homes or hospices won't have a bar of it.
Mm-hmm.
Is that true now, and how much sway does your opinion have if you put it in your advanced care plan?
So that's actually a lovely question. I'm glad you asked that. Your advanced care plan kicks in and works for you when you have lost capacity, lost the ability to make a decision for yourself. With assisted dying, you have to have capacity all the way through the process until they administer the medication. And it's because people, the way New Zealand law is set up, people need to be able to consent, even if it's just, squeeze my hand if you want this to go ahead, and they can squeeze it, or squeeze it twice if you don't want me to do this. So there needs to be some level of communication and consent on the day the medication is given. And so assisted dying requires there to be capacity, and advanced care planning does not require there to be capacity. Some people want to have both in their advanced care plan. It's just useful to know that legally we can't act on it if assisted dying is written in your advanced care plan, because the way the New Zealand law is, we can't do anything with that if somebody's already lost capacity. What was your question again? Do some facilities not offer it? Yeah, some facilities don't offer it or allow it to take place. However, I think things have shifted and changed over the years in that now, because healthcare professionals are more experienced with it, we can see that some people worry less because they know and they feel more able to have control by accessing assisted dying. And actually a lot of people who go through palliative care, investigate assisted dying and do advanced care plans, actually they can be a very similar population, that actually people are looking at what are the options available to them and investigating how decision making might be able to reflect their wishes. Also, they want to cover both options. If I have capacity, they might go for assisted dying. If I don't have capacity, I want to make sure my advanced care plan is available, and absolutely they'll do what I want. And so some people will be progressing with both.
Can I ask, what I found doing the advanced directive,
Yes.
what was quite tricky, your helpful website, does it have examples?
Not of advanced directives, and this is one of the...
I found that that it's quite hard to construct statements.
Yes.
With a standing start.
Yeah.
So and I'm wondering why, I think I know why you haven't, but
However, it is something that the National Lead is now thinking that we should probably work on.
yeah, I think there needs to be more pro forma things, because
Yeah.
what worries me about hubby's one is how it's interpreted.
Yes.
Yeah, because he can write that he's got what he wants there,
Yes.
but
It is.
so has he nailed it?
That's right, and that's a conversation to be had.
Yeah.
And one of the things, so that it does lead me on to, like, why are we doing these conversations at the general practice? Why don't we just have these conversations, between our families? And the reason why is because actually hearing other people's understanding of what our plans are for ourselves is really helpful and really useful. and it helps us with how we write our plans. And so we might have an idea about what we're trying to achieve. I'm just going to grab a plan. We might have an idea about what we want to achieve, and then write, say, an advance directive, thinking that's what we're going to get at the end of it. And you talk to somebody in the healthcare team and they're like, oh, I can think of, you know, several other ways that may be misinterpreted, and it might be clearer if we write it in X, Y, and Z. So that's one of the reasons why we say have a conversation with your healthcare team, usually at your general practice, so that you can clarify what it is that you want. If you have time, I know we had a wee bit of a late start. If anybody has to leave, then you're absolutely more than welcome. I thought I might spend a wee bit of time just going through the plan, and then I can talk to what's particularly useful when you're filling out your advanced care plan, and any pieces that I might be able to clarify some of the advanced directive bits, if you like. Because there are some ways to make it a little bit easier. So on page 2, it starts with the number 2, it's got the number 2 at the top, and it says what matters to me. And you can write whatever you like in there about what matters to you. I would also encourage you to not get too hung up on it, and you don't need to overthink it. It's like, what is your good life look like now? What do you enjoy doing? What matters most to you? And that's really what that's trying to capture. And everybody is really different. And so what matters to you will be different to what matters to other people. So it's just trying to get a picture of who you are as an individual. On page 3, there's the what worries me section. The what worries me section is really super helpful if you have things that you're worried about. If you don't have things that you're worried about, you don't need to write. You don't need to cook up some worries just to have something to write down. But for some of us, it can be that might be why we're doing our plan. It's like, oh, I'm a bit worried about, I don't know, X, Y, and Z. It's like, you write it down. Because if we understand what you're worried about, that might turn into your advanced directives. I'm worried about losing my independence. I'm worried about, I don't know, my brain not working like it used to. Whatever it is that you're worried about. It helps us, on page 4, it talks about why I'm making my advanced care plan. And it's useful to write in if you've got a diagnosis about something. That helps me know that you meet subsidy criteria, and I'm like, yeah, that's a cheap appointment for sure. And kind of your understanding of where things are at with your health. So anything about what's related to your health, or it might be that you're making an advanced care plan because you're worried about your family, great. You can put that on there on page 4 too. Page 5 is thinking about your future, and you don't have to fill that page in. It's, if you don't want to. I quite like page 6 because it's tick boxes, and I think if things get complex, having some tick boxes makes things feel a bit easier. If you don't have an enduring power of attorney, you might have a best friend who isn't, or a good neighbour or somebody. You can write their name in here if they are the person that you want to speak on your behalf. You can put their details in here, and we know that the healthcare teams, certainly at the hospital, look at this information, and they might receive a phone call one day if there's some health event. It's also useful to know that legally the EPOA is always an EPOA in waiting until it becomes activated, and it's only activated when you have had an assessment to say you've lost capacity. And so while you have capacity, all of the decision making is yours. Good. Until there's this assessment, and it's a proper assessment that usually, doctors who have it within their scope of practice they have to do this assessment, they have to activate the EPOA, and then the EPOA is able to make decisions. And the expectation is that if you have an advanced care plan, your EPOA is expected to step into the shoes of the person who they're making decisions for. So they're expected to make decisions along the lines of how you would have made them for yourself. And so they often appreciate this and use it as a guide for them to make decisions, because it's like, right, they've left me a plan, I'm doing it, I'm doing what they want.
You can actually have, this person is number one EPO. If they can't function in that position or are not available, you can nominate a second.
It's a successor, yeah, you can.
Successor, yeah.
That's right. And so if maybe your key number one EPOA is out of the country, or for some reason they are also unavailable, then yeah, the successor can step in and act on your behalf.
It's different from property EPOA though, isn't it?
Yeah, property EPOA you can have two.
Yeah.
You, but for health and well-being, you can only have one
Yes.
who is the decision maker at the time.
No, sorry, I'm saying for the property EPOA, you don't have to have a GP assessment.
No, that's right.
Yeah, just want to clarify.
Probably, yeah, I think so. Yeah, that's right.
Yeah.
And I think for the property one, you don't need to have lost capacity. They can make decisions on your behalf.
Yeah, you have a choice on the form whether you can say, I wanted it only to come into effect if I lose mental capacity.
Yeah.
Or I want it to come into effect while I retain mental capacity and continue if I lose it. Or words to that effect.
Yeah.
Yeah.
Yes, it is. Yeah, go on.
Tricky stuff.
It is.
Do you have to have a lawyer organising the EPOA?
Not as far as I'm concerned. There are some. I think there are some low cost legal. I think to have it officially signed off, you do. If you're doing an advanced care plan, you could just put your named person in here, and so lots of people do that. There's nothing officially set up through the lawyers, but there's a box that says, I don't have an enduring power of attorney, but I really want you to talk to this person. In the pragmatic world of the hospital, they'll absolutely talk to them as much as they'll talk to anybody who's named in here that you want to be involved in your care. Other people have people that they really don't want involved in their care, and so they'll say, don't include them. So we can take that on board too. But if if you have somebody who's overstepping, you can, I was going to say you can get rid of them, but I mean, legally, out of your plan, you can get rid of them. And on page 8, it says, as I'm dying, my quality of life means. For me, that means around, do you want medication? So this plan definitely talks about dying, but dying isn't the only reason why we have a plan. But some people really do not want pain-relieving medications. Some people really don't want other types of medications that will help them feel better. That's fine. Other people definitely want all of the medications. And so because everybody's got different preferences, this is the spot to write that in and enable people to understand what you would like. And sometimes there are bits and pieces that don't tend to fit anywhere, and so then it says other details I'd like you to know. You just write in whatever you want there. That's completely fine. On page 9, it's saying when I'm dying, the place I die is important to me, yes or no, and then there's a list of places. It's useful to have a couple of options. Some people really have a strong value about dying at home, or other people not dying at home, whichever, everyone's different. But if you have a plan B of another place, because sometimes at home doesn't really work out for whatever reason, and if somebody needs a wee bit more intervention or support, so sometimes a hospice or a care facility to have some nursing care and some nursing support and have that be available. So it's useful to give a couple of options, so that if things get a bit hard for family, maybe they know that going to a different location is fine. That music, I know. On page 10, we have got my treatment and care choices. There's a question about what seriously ill means to you. It's useful to fill that in about what's seriously ill, because we're going to use your plan when you become seriously ill, so it's useful to know what that means to you. And then picking an option. It's useful to just pick one, because if we pick two, or we pick two different numbers, then actually paramedics or people might not know which one you're meant to go with.
So take the dice.
Yeah. Some people are, certainly people with a diagnosis that they're worried about, might be like, well, while I can get back home, I'd like you to do all of the interventions. So you could choose option one, and then
You'll meet someone in the cafe at 11 o'clock.
that's okay, no problem. It says the exceptions to this would be, so you can choose option one and list some exceptions of when you would not want that to still be the case. So with a diagnosis, it might be, while I can still get back home and living my independent life, I would like to have all of the life-prolonging interventions. Except, if I can't get back home, if I can't get back to living my independent life, maybe I don't want all of the life-prolonging interventions. It depends where the exceptions are. Or other people might be, if I can no longer recognise my family and I don't know who they are, then I don't need all of the life-prolonging interventions at that stage. And that's a way that we can incorporate those things that we're worried about, or those things that we value most. We might be able to write the plan in a way that helps you achieve that. And then on page 11 was the advanced directives. And again, that gives us an opportunity to communicate things that we're worried about, and it depends what your values are. For some people, they might have an advanced directive around if I've lost the ability to drive, or if I've lost the ability, like I said, recognise my family, if I've lost the ability to live independently at my own home. But it depends who you are and how you know, what matters most to you, really. Some people also have some of the cancer patients that I've looked after over the years living, you know, got a busy and active life. They still have a terminal diagnosis, and they are getting on with life at the moment. And the way we can phrase it with that is, if I have an acute illness or injury and you can get me back to living independently, I would like you to do that. However, if I'm dying of my terminal illness, because they're recognising the fact they have a terminal, if I'm end stage palliative terminal, whatever the diagnosis is, then I would like comfort measures and for you to not prolong that end stage. See, I think you're right. Having some examples on the website would be helpful. Yeah.
That's not noxious, or I guess the worry is that it would be leading.
Leading, I know. That's what I think. It could be leading. And I base my examples on the fact that I review plans. I do this job Monday to Friday, and so I review plans all the time, and it's reflective of the things that I see people worrying about. And I've kind of over the years worked out that actually you can write advanced directives around the things that people are worried about. They're worried about, you know, losing the relationship with their family, or they're worried about, you know, some people really don't want to go into care, or some people, you know, it's whatever the worry is. I'm like, oh, I'm pretty sure we can rephrase that to have that be an advance directive so that people know not to prolong life at that stage if that's what you're really worried about. And on this page, oh, I'm running over. On page 12, there is the signature page. This is the kind of signing off, decisions have been made. The healthcare professional signature, lots of us have healthcare professionals in our family, don't have one of them sign it. This is really helpful to have a third person, a third party, so that it's really clear that you have. So family is super helpful to have fill in the rest of the book and have these discussions, but for that kind of third party check to make sure that nobody's pushing you into the decision, it helps to have somebody else do it who's not family. And so the healthcare professional doesn't even need to agree with your decision. The healthcare professional is saying that at the time that you created the plan, you were able to make decisions, you had a clear mind, good decision making, able to weigh up the pros and cons. You had a good discussion and you understood the care choices that you might face. You had adequate information, and so if there are things that they are worried about, able to just discuss it with you and say, have you thought about X, Y, and Z? Or, oh, I'm not sure that's going to help you achieve your goals, let's have more of a conversation. So adequately informed, and you're making this plan in a voluntary way. So that's why the fact that family members might be the ones doing the coercing is the reason why I say have a conversation with somebody who's outside your family. And then there's on page 13 and 14, it's talking about after you've died, and people have opinions about buried or cremated. You know, some people might write in there what they would like for their funeral or tangi, and some people have kind of bought the plot already, and it's like that's where that information might go as a way of communicating that to the family usually about what happens next. And then on the back is kind of where documents and stuff are kept. Any other questions about that lot before we wrap up? I know we're absolutely over time now. Oh, wait.
Where do people in a cognitive decline relate to the
The care planning?
Yeah.
Yeah, so with people with cognitive decline are still able to do an advanced care plan, and sometimes it can be communicating long-held beliefs, and there's a capacity assessment. So it's in a capacity assessment, the judgment is around are these long-held beliefs, and the other things escape me, and now I'm having my own cognitive decline moment. Give me a minute. I'll have a drink of water.
And capacities for the specific
Oh.
purpose that it's intended for, so
That's
creating.
right. That's right. So capacity is decision specific. Capacity is decision specific. So it might be that somebody is forgetting to take their tablets, but they're very clear about what they do and don't want for their own health in the future. And so actually, people can be experiencing cognitive decline and still develop an advanced care plan. For somebody who has lost capacity, in Canterbury we have a thing called a medical care guidance form, and the medical care guidance form is useful for people still living at home but they don't have capacity to make decisions anymore, and the EPOA/family can make care decisions on behalf of the person with the GP or the practice team. And so we have a couple of options. The medical care guidance form isn't used very much, but it's quite helpful for family members and reduces worry for family members. And again, the expectation is that family and the doctor will be making care decisions aligned with how the person would have chosen for themselves if they could communicate at that stage. So I think in Canterbury we've got a couple of different options. But that's also why I say start early, because I want to make sure we get people's thoughts and perspectives while they're well, and I'm trying to get ahead of cognitive decline, obviously. You've got to start somewhere. Thanks. Any other questions?
The shared goals of care, there's a pro forma for that, is there? It would be good just to see what that looked like. You know,
It's a for patients, or for people, for all of us, we should experience it as a conversation, and the form or the plan is for medical staff to fill in. And our experience, so the document has been developed, isn't a patient-facing document. It's not a person-facing document. But there is information on the website that I was talking about around shared goals of care, and there's information for families.
Yeah, because as a caregiver, it's always good to be forearmed, because this is, it's going to happen.
Yeah.
A couple of times, so you enter through ED, and to have an idea of what's going to happen actually helps.
Yeah. It really does, so that you can. You are able to advocate. Yeah. There's some information on the website around shared goals of care and kind of helping to start that thinking early. Yeah. Go on.
I just wonder if the person isn't up to travelling and sitting with a GP or practice nurse for an hour or more, however long it takes. What, in your experience, what agencies could you recommend? So if we're wanting a third party to engage in the process, rather than me working with my husband on the advanced care plan, it'd be quite nice to actually, and he may feel more able to express his wishes openly to an independent person.
True.
Are there agencies you can approach to engage in that process, or would your expectation be that the residential care facility has sufficient knowledge and understanding to guide someone through the process?
Most residential care facilities, some of them might. A lot of the staff probably don't have the ability to do that, just because often they're staffed by quite junior staff people. But the general practices, depending, because they're all different, some of them will have a nurse that will travel out and do advanced care plans with people in their place of residence.
Right, whereas his GPs actually get the residential care facility.
Oh, okay, yeah.
So I'm just wondering, is there Citizens Advice Bureau, or are there other agencies who can take a role in assisting people who may want?
Some of them do, some, and it then comes down to individuals who feel confident and being able to ask these questions. And that can be any of us. So some individuals feel more confident, others don't. I couldn't name a specific one, because actually it's more of that there's an individual who works there who does them a lot.
I think it could be something quite useful.
Yeah, I think
in
so
the
too.
community.
Yeah, and that's one of the things that we're working on, is having community teams feel more able to participate in these conversations. Yeah. Fab. I will finish up now then. If you have any other questions, you can ask me when we're finished, and I'm just packing up. But yeah, thanks very much for having me.
Thank you.